Okay, so now we're going to move on to chapter 22, talking about GI dysfunction. Now, I will tell you that this one, this recording is going to be combined with 22 and 26, as they are most definitely less in-depth than the respiratory chapter. A lot of what's on the slide comes again right from the book, where I'm using the book PowerPoints. Some will have extra to it and some will not, so I will be going over some of these slides pretty quickly, just because they're so straightforward. Okay, so obviously, as a quick review, these are the components in your body fluids. This is what needs to be there. When it comes to fluid volume requirements, obviously we need the appropriate amount of fluids for growth, especially in our infants, for water balance. It impacts your beta metabolic rates, your kidney function, and we will talk about kidney function more in depth in the GU lecture. And then there are going to be times where a body will need increased fluids, particularly for pediatrics. That's going to be your things like fever, vomiting, diarrhea, burns, which we're not going over, but just in general. And then even things like tachypnea, they're going to need more fluids. You would need decreased fluid volume requirements for things like heart failure, after surgery, post-op, and in instances of increased ICP. So when we talk about dehydration, there's a couple of kinds, and this should be a review from Patho, so it's going to go pretty quick. You have isotonic dehydration, where your electrolytes and your water loss are about in equal proportions, and this is the kind that is primarily what we're going to see in kiddos. And then you have the hypotonic and hypertonic. So the differences in those is which one does your electrolyte deficit exceed the water deficit, and vice versa. The different degrees of dehydration, I'm not going to put that all up here because, again, it's laid out very nicely in a nice little table for you. It's on page 694. And the pieces that I want you to focus on are the weight loss percentages and the vital signs. So how much percentage is estimated to be lost in weight when we have mild dehydration compared to moderate dehydration. Part of the reason that the GI lecture is going to go pretty quick is because some of these things we've kind of already talked about when it comes to kind of malabsorption versus like in failure to thrive. Do we just not have enough calories getting in? Is there a malabsorption issue? The GI stuff is much more straightforward than our respiratory stuff. We have an impaired functional integrity. That's going to be that component of failure to thrive that we were talking about before. That's going to be your GERD, spitting up and regurgitation, and constipation. Your fluid, or your losses of fluid, and your specific absorption disorders, you're going to have things like nausea and vomiting. You're going to see diarrhea, and this is where you're going to see actual GI tract anomalies. And then we're going to be talking about inflammatory disorders briefly, focusing on like Crohn's disease and ulcerative colitis. So let's talk about diarrhea, everybody's favorite, so common in pediatrics. Acute diarrhea is the leading cause of illness in children younger than 5. And in developing countries, 20% of all deaths are actually related to diarrhea and dehydration because it can be so severe. When we talk about acute infectious diarrhea, there is a large variety of causative organisms. I'm not going to make you know all of those, okay? And so when I say that there's various types of diarrhea, so we have acute, and that's going to be related to your like upper respiratory infections, your urinary tract infections. It can be like secondary to antibiotic use, and other acute infections. Now, in the past, I've had students be like, well, how could diarrhea be related to an upper respiratory infection? If you think about the way that that works, and hopefully you listen to the respiratory lecture first, you have all of those pathogens up in your face, in your nose, you're swallowing them, eventually they'll start draining from the ears. So if you're a kiddo and you're swallowing all those pathogens, where are they going to go? Down into your GI system. Urinary tract infections, the same question comes up. How could you have diarrhea with a UTI? Well, again, think about what is going on down there. Antibiotics, we know that the common side effects for antibiotics include loose stools, diarrhea, especially in kids when we talk about amoxicillin or augmentin, particularly the augmentin component with the beta-lactamase in there. Whew, that will cause some diarrhea in a kiddo. So I always try to prep parents for that. Then we have, chronic diarrhea. So that's going to be a duration of more than 14 days of diarrhea. And often that's going to be caused by a chronic condition. So it's going to be secondary to something that's already happening, but not always. Then there's intractable diarrhea of infancy. So that's a syndrome that occurs in the first few months of life. It's diarrhea in the infant that lasts for more than 2 weeks and is refractory to treatment, meaning nothing that we give that poor little kiddo is helping. Most commonly, intractable diarrhea of infancy is related to acute infectious diarrhea that was not originally appropriately managed. Then we have chronic nonspecific diarrhea, also known as toddler's diarrhea, and this can happen anywhere in the range of 6 to 54 months old. I'm not going to go into huge detail on this one. If you're interested, it's in the book. I have seen, in the few years that I've been practicing, I've seen toddler's diarrhea once. I think he was somewhere between 18 and 24 months. And he went through the gambit of testing to rule out organic causes, infectious disease, anatomical issues, and in the end, it was toddler's diarrhea. So just kind of be aware that those are kind of the main focuses of where the differences lie. So then we've got gastroenteritis, rotavirus, bacterial infections, and then again antibiotic associated. So rotavirus, I feel like everyone should have at least heard of that, maybe not necessarily in reference to pediatrics per se, but rotavirus can be really gross. I remember having a kid on the floor who had a rotavirus infection, and it was just diarrhea city all night long. That poor kiddo was so miserable. Then we've got obviously your bacterial types, and then antibiotic associated. So more so, again, in kids, we're talking, something like an augmentin, but think too along the lines of C. diff. Okay. Then, you've got your enteritis, your colitis, and your enterocolitis. I don't expect you to know the fine inner workings of all of these. Just be aware in general terms that this is what's going on. So the main thing here that I want you to really be aware of is this oral rehydration therapy and prevention. So oral rehydration therapy, we're going to talk about that in just a hot second. Prevention. So what does that come down to when we're talking about diarrhea? Good hygiene, hand washing, and in little kids that can be really hard for them to do. And that's the big piece, that trying to prevent the spread of infection. So oral rehydration therapy, This can be commercially prepared, or this can be, home recipes. So now we're talking like Pedialytes. I do know there's a large population of families in the state that believe in doing their own home remedies. From the nursing and provider standpoint, we can only, recommend best practices and assess for safety in what's being provided, and giving our education as best as we can for that. So when we're talking about either or rehydration, the replacement is going to be a 1-to-1 loss, okay, for diarrhea. And this is where you're educating families on giving it in little bits at a time. And I'm talking about like a tablespoon every 10 or 15 minutes, dependent upon how severe it is and if the diarrhea is happening in conjunction with nausea and vomiting, which typically they go hand in hand, but not always. So how much they give at once is going to be dependent upon that. If there is nausea and vomiting associated with it, it's going to be about a tablespoon every 15 minutes. If they're able to tolerate PO a little bit better, you can go a couple tablespoons at a time. But the goal is for the child not to gulp it down. Because if this has been going on for long enough, they're going to be really thirsty, but it can just continue to upset their stomach. And we want them to maintain that hydration. Okay. For our infants, when we're talking about oral rehydration, that, yes, can be used alone or in combination with breast milk or formula. That's a longer conversation than I feel like you guys need to get into, but just be aware that that is possible. So again, such a focus on prevention. I mentioned the personal hygiene because obviously most diarrheal infections are spread from the oral fecal route, and kids are kind of gross. But I feel like as the pandemic is really highlighting, people in general terms were not that great at hand hygiene to begin with. So hand washing, if your hands are visibly soiled versus using, how can I draw a blank on this word? Hand sanitizer. And I feel like at this point you all know that. If you don't, please just review it. Water, that's a big component here. Drinking clean water. Careful food preparation, washing vegetables, keeping meats separate, things like that. Okay. And so from the nursing role, again, that's going to be one of your big pieces of health education, whether you're on inpatient or outpatient in the pediatric world. Okay, so on the other end of that spectrum, literally, we have constipation. Constipation may be secondary to something else going on, or it can just be like a functional constipation, and we have no idea why it's happening, but it is. And then there's chronic constipation, which can occur for a slew of reasons. I can tell you, from a nurse practitioner standpoint, I talk about poop more than I ever thought I would. I, even as a pediatric nurse, did not realize how prevalent constipation is. Kids just don't know about poop, and parents also are unaware about poop and constipation and actually how quickly it can occur. Because you can actually have constipation and have diarrhea. So it's not always super intuitive. Like my child hasn't had a bowel movement in 3 weeks, and so now I know for sure there's constipation. If it seems like they're pooping every day, but it's not a full evacuation, if it's, being in Alaska now, everybody calls it moose poops versus, a soft formed consistency, those pieces all play into constipation. So when we're talking about constipation in the newborn period, reminder here, first meconium should be passed within that 24 to 36 hours of life. If not, we're going to be looking at specific organic causes like Hirschsprung's, which we're going to get to, hypothyroidism, which can be a big component of that. And is there something going on like cystic fibrosis in the kiddo? So there would be like a meconium illicus or meconium pluck. In infancy, constipation is most often related to diet. And this is huge. It can be a very big stressor for families, especially first-time parents. For kiddos who, for whatever reason, whether it's maternal choice or due to maternal challenges, for kiddos who cannot be breastfed, we will see constipation almost indefinitely in some capacity in our formula-fed infants. And I try to prep parents for that so that they know ahead of time what to look for so that we can be a little bit more proactive instead of just reactive. And I think it's also important, so letting parents of exclusively breastfed infants know that there is a difference here between constipation in the exclusively breastfed infant and just not having as many stools. That from my standpoint, working in pediatrics in the outpatient setting now, that's been a big factor of my educational pieces. So, constipation in childhood, this is where I see it the most, and in adolescence. Most often, this is not related to like an organic medical cause. This is going to be related to environmental changes, like not wanting to poop in public, or control over body functions. So, it's this vicious circle when we think about constipation in the childhood age. If kids are constipated, usually they have big hard poops, and that's painful. So as a reaction to that pain, they withhold from going, which just exacerbates the overall issue. And we talked briefly already about encopresis and how constipation can lead to encopresis. But constipation can also result from stress. That's a well-known fact. So kiddos who, particularly those who are coming from homes where there's significant maltreatment, toxic stress, constant changes, even if there's not maltreatment going on, this can be a big factor to it. Constipation can actually impact the occurrence of UTIs, and we're going to talk about that more in the GU lecture, but just be aware here that it can cause not just problems with bowel movements, but other issues in the body, and that's why it's so important. So, Hirschsprung's disease, I said we're going to talk about that a little bit more. If you've never heard of this, it's also called congenital aganglionic megacolon. And it actually accounts for about 1/4 of all neonatal intestinal obstructions. And it is a mechanical obstruction from the inability of the intestines to move things appropriately. It is more common in males, also more common in kiddos with Down syndrome. The rough incidence is about 1 in 5,000 live births, but I can tell you I've seen more kids with Hirschsprung's disease either in their history as having been resolved due to early detection and corrective surgery, or having seen it in the newborns. And this was specifically when I was at South Central Foundation. And I know Dr. Chambers has also talked about how often she's seen it since working in Alaska compared to working in another state. So that's just an anecdotal, hey, this is actually a thing. It's not one of the ones that we're just talking about that you'll never encounter. And so when we say aganglionic, obviously that means that there are no ganglion cells. So a quick patho breakdown If there's no ganglion cells, then we have a loss of that rectosphincteric reflex, which means that overall there's an abnormal microenvironment of the affected intestinal cells. So we're losing that enteric nervous system stimulation, which overall decreases the internal sphincter's ability to relax. And so here you're going to see that. So here's the aganglionic portion. So due to all of those things I just said, things aren't happening. And then you're going to have a distension over here. Okay. So clinical manifestations, like we just saw in that photo, you're going to have distension, you're going to have an accumulation of stool. So fecal matter is still accumulating. It just cannot be released because that sphincteric reflex is not happening. So as a result, something like an enterocolitis may occur. But what we're going to see in infants, which is a big key in, is the bilious vomiting in infants. Also, explosive watery diarrhea. And if this happens to go on into childhood without being detected, eventually they're going to have very characteristic ribbon-like and very foul-smelling stools. So to determine this, we're going to need x-rays, we're going to get a barium enema, there's going to need to be some exams, and then confirmation does come with a rectal biopsy. So for management, it's going to be surgery. So from the nursing standpoint here, pre-op care, so these kids may not be well enough to have surgery right away, depending upon how severe it is. So first there may need to be some kind of symptomatic treatment with enemas to clear them out. They're going to have to be on a very specific diet, low fiber, high cal, high protein. And a big important thing here for nursing is going to be measuring abdominal distension circumference. So why would that be so important? It's just like when you get a wound or a bug bite and we mark around it to see if that erythema grows or if the swelling grows. Same thing. Okay, post-op care, that's going to be the same as any kind of surgical post-op care. The discharge planning here, there's going to be a lot of education that needs to happen with families here and a lot of support, especially if this is something that was caught, in the newborn period. These families need a lot of support. So utilizing your referrals, utilizing your resources in order to facilitate that for families is going to be crucial. Okay, so vomiting, real brief. I feel like it's been brought up quite a bit, just kind of incorporated because it's not always a standalone. But something that I want to draw your attention to is understanding the difference between non-bilious and bilious types. This is something that I would actually recommend for your own knowledge, not just for pediatrics, but nursing in general. If you're sitting here listening like, what is she talking about? This is something that I would look up as far as pictures go, because that's really going to help you understand what it looks like and what it means. Okay. So as far as therapeutic and nursing management, it's going to be all these components that we've talked about. Getting a good history and doing a good assessment, determining if the vomiting is secondary to something else. And if it is, how acute is it? Where is your level of concern being elevated to? Is this, a GI virus in the beginning of the fall? Or is this, a bilious type of vomiting that's going to be associated with something else like we just talked about, like Hirschsprung's? Or coming up here talking about pyloric stenosis. Is it projectile? So vomit is not always as simple as it seems and really does need a good history and assessment being taken from the nursing standpoint. Oral rehydration so that they do not get to that severe dehydration is going to be so important. So again, educating on that and maintaining that. Okay, so GER or GERD, as you may have heard it, it's defined as the transfer of the gastric contents into the esophagus. at its most simplest definition. Those who are predisposed to having a GERD type situation, those with neurological impairments, a hiatal hernia, morbid obesity, our preterm infants, those with asthma, and those with CF. And then prevalence, it's really common. I was actually pretty surprised at how common it was, in infants when I started clinical and seeing it diagnosed from the get-go versus just seeing it in the history as a peds nurse. So GER is going to occur it does occur during the day, and it's going to occur most frequently after your meals, but at night because you're laying down. So that makes it easier for that transfer of gastric contents to occur into the esophagus. And after meals, it's because you're full. So thinking about somebody that has like a hiatal hernia, that musculature is already weak, makes it easier for it to be transferred. There's a whole slew of things for diagnosis, but I can tell you from practice, most often it's based on history, just like 90% of everything else in pediatrics. Management is going to depend on how severe, and the age. So managing with diet and positioning is obviously going to be the first line choice. If we have to go the medication route, it's going to be H2 antagonists. Ranitidine was my preferred go-to prior to all the hubbub that occurred with it in the last year. Pepsid, Zantac. It really depends upon the age on which one is going to be the preferred first line of treatment. So, acute appendicitis. Here we have, I know not everyone's heard about it, but what exactly and how does it occur? So, acute appendicitis, obstruction of the lumen or the opening of the appendix, usually going to occur by hardened fecal material. There's a couple other things that can cause it, but usually, again, hardened fecal material, which leads to the secretions, the outflow of those secretions in the appendix being blocked. So with a blockage, what happens? Of any kind, pressure builds if you have something that's supposed to come out but can't. So pressure builds within the lumen, and then the blood vessels are compressed. So if it's not caught soon enough, that compression is going to lead to necrosis, which is going to cause that perforation or rupture, and that can lead to peritonitis. So that's kind of your basic patho of what goes on there. In kids, this is usually not something that leads to super extensive complications. Very unusual. And early recognition helps with the prevention of that. So CT scan is going to be your gold standard, but I can tell you from practice, insurances don't always want to pay for that first. Getting a good history, again, I know I keep saying that, but that's really important. Surgery is, the book will tell you that's first line, and we will go with that for your exam, but I can tell you from practice and from emerging research, that's not always the case. They are moving away from surgery and trying to manage with antibiotics and less invasive options first. But for your purposes, surgical removal is going to be the way to go. And your role here is going to be just like any other post-op care. And the big piece here is going to be pain management. Because a lot of times this is one of the, again, could potentially be one of their very first times that a kiddo is hospitalized. Definitely very commonly the first time that they've had surgery. So a lot of components to think about. So inflammatory bowel disease, and I want to make the distinction that this is IBD, not IBS. Okay. This incorporates or encompasses both ulcerative colitis and Crohn's disease. And so ultimately, the etiology is still not fully known. We don't always know why a kiddo has this. And so in ulcerative colitis, you have inflammation that's limited to the colon, and it affects the mucosa and the submucosal lining with varying degrees of ulceration, bleeding, and edema. Where Crohn's disease can affect any part of the GI tract from the mouth to the anus, but it mostly affects the terminal ileum. Just FYI. So diagnosis, there's a lot of things going on here. We're going to need a good history, physical exam, labs, stool samples. It's a very involved process. The overall goal for either one of these is going to be, just like everything else, maintain as much functioning as possible. So we're going to call it remission because this is a chronic issue. And the way that that occurs is, one, through nutritional support. So diet will likely have to change for almost everybody with this. There's also meds. So steroids are used, 5-ASAs, immunomodulators. There's a whole slew of medications. I don't expect you to know all of them, okay? What I want you to focus on is understanding that the nutritional support is so very important here. And surgical interventions are only going to be indicated if our other modalities fail first, because that would have to then look something like a total colectomy or an ileostomy. Okay, so moving on to biliary atresia, and I do want to mention, please do take the time to look at the hepatitis section in the book. We're not going over it here because it's so straightforward, but just be aware of the generalities of each of those, okay? So biliary atresia is it's also known as EBA or extrahepatic biliary atresia. It's a progressive inflammatory process that causes both intrahepatic and extrahepatic bile duct fibrosis, ultimately resulting in ductal obstruction one way or the other. And we don't know, again, this is one of those things that we don't really know why it's happening. So early detection is key. And I mean like early like infancy, because treatment by 2 months is critical to having more positive outcomes and prognosis. That treatment is surgical. Now, the prognosis, if untreated or not caught soon enough, is not that great. So we're looking at progressive cirrhosis and likely death by 10 years old. However, if it's caught early and children have the surgical intervention, then the long-term survival with the surgery jumps drastically to 75 to 90%. So just know this is one of those things that has to be caught early for there to be positive outcomes. Okay, hypertrophic pyloric stenosis, a big one to know. So at its most basic definition, we're looking at constriction of the pyloric sphincter. Constriction of the pyloric sphincter with obstruction of the gastric outlet. So what does that mean? That means that the circumferential muscle of the pyloric sphincter, so the surrounding muscle, becomes thick, resulting in this elongation and then narrowing of the pyloric channel. It's going to develop in the first few weeks of life, and this is where I was talking about understanding the difference in bilious, non-bilious vomiting. This is another example of why that's important, because this will occur, a symptom of this is going to be non-bilious vomiting after a feeding. So knowing to ask that question when a parent calls you about vomiting can help you key in to things that are going on like this. And this is another one of those things that needs to be diagnosed early, or, think about it, if I'm telling you that this pyloric sphincter, they can't get anything out of it, nothing's passing through, then there's not going to be absorption of any of the food. So we're going to end up in a failure to thrive situation. Clinical presentation. This pyloric stenosis has a very characteristic clinical assessment finding, and that's going to be an olive-like mass when you're palpating the belly. That non-bilious vomiting is going to occur about 30 to 60 minutes after eating, and it does become projectile. So if you hear projectile vomiting, you need to do a good assessment. Is that like the kid puked and it went in front of him, or is it like hitting the wall? And I've literally had to use that distinction in assessing for a projectile, because for a concerned parent, projectile may mean something very different than from us on the medical standpoint. And then the treatment surgery is the gold standard here. And so here you can see what I'm talking about. So hardly anything is going to be able to get through there. And so then if they're eating, about 30 to 60 minutes afterwards, if it can't continue on, what happens? That pressure builds and it's going to go somewhere. The only place it has to go is up and out. Intussusception, another one of those really crucial diagnoses to be aware of. It's the telescoping of one portion of the intestine into another. It typically occurs from ages 3 to 3, so 3 months to 3 years, but most commonly you're going to see it in kiddos under the age of 2, and it's more common in males. So we don't always know why this happens. Another one of those things that happens that's dangerous and we just don't know why it's happening. So when I say telescoping, a better description of that, so the proximal segment of the bowel scoops into a more distal segment portion, and that's going to pull the mesentery with it. So when that progresses to where the pressure equals arterial pressure, blood flow stops. And again, when we have blood flow stop or constriction or pressure, then we have ischemia. And so then there's going to be pouring of mucus into the intestines. You will then have venous engorgement. So then there's going to be blood and mucus leaking into the intestinal lumen. And so that's where the classic current jelly stools description comes from. Just like in pyloric stenosis, there was that very characteristic piece with the olive-like mass. This one, the intussusception characteristic that is very common and classic, is the current jelly stools. But there are additional signs and symptoms to know about, because if you think about the patho that I just gave you, the current jelly stool is going to be a late presentation because that ischemia is already happening. So prior to that, box 2210 has a really good description of these things. So there's going to be things like sudden acute abdominal pain. The kiddos are going to be screaming and drawing their knees into their chest. But in between the episodes of pain, they're going to be normal and feel comfortable. When we're talking about assessment and palpation, intussusception has a characteristic sausage-shaped mass in the upper right quadrant and an empty lower right quadrant. So thinking about that, I told you it telescopes. So if it's being pulled into one piece, that makes sense, right? And there's likely going to be vomiting. And if the vomiting and the current jelly stools occur, those are late signs and indicative of pretty severe telescoping. Okay. Treatment is conservative treatment is going to be like an air enema or a saline enema. And if it's a late presentation with that current jelly stool, then surgery is going to be the way to go. And so here you see what I'm talking about, that that it's pulled, it would be pulled in up here, okay? All right, malrotation and volvulus. So a malrotation is obviously what it sounds like, an abnormal rotation, and this is going to be around the superior mesenteric artery during actual embryonic development. Volvulus is twisting of the intestine around itself, and so any kind of twisting of an intestine, we're talking about compromising the blood supply to the intestines, with all of these things being as possibilities then. Malabsorption syndromes, there are a few of them. We've talked about it a little bit. This is where that chronic diarrhea is going to come into play. Failure to thrive is going to be here. And then there's these 3 different defects that it can be kind of like sorted into main buckets wise. Celiac disease, I have this on here only because in clinical practice, I've seen an increase in parents feeling like their kids have gluten intolerance, but then there's the true celiac disease. I don't need you to know this super in depth. If you knew what was on this slide, that would be appropriate enough. Same thing with this one, knowing the basics here, okay? All right, so I'm going to pause it. I'm going to pull up the next PowerPoint, and then we'll finish up. Okay, moving right into GU. Now, these first couple slides on here, I am just going to like plow through because it really is just a reminder. I had a few people say that I've been saying that some of the assessment pieces should be reviewed, and it should be, but I've been told that it's not necessarily a review for you guys. So I'm kind of interested in where that disconnect is, on if people are leaving off PED stuff prior to getting to us, or what's happening with that. So if you have any feedback on that, I'd definitely be interested in hearing. Okay, so when we're talking about the renal system assessment, 2 pieces that are going to be really important here are palpation and percussion. Now, percussion I know is not, it's something that's talked about as being part of every physical assessment, but I think we all can safely say it doesn't always occur. But percussing the kidneys can be a really important piece of assessment information that you're able to gather. Important health history info. I'm not going to read all these to you, but really anything that kind of deals with that. And I think a lot of times people forget that the GU system also incorporates sexual intercourse history, things like that, like STDs. So that falls under here. Medications, important things here because things like taking anticholinergics can impact the renal system without people really thinking about it. And then patterns of elimination. You know, I've been talking to you about poop for a while now, so obviously now talking about elimination from the standpoint of voiding is going to come up. But like we just talked about, constipation and poop are still going to have a role here. So if you look in the chapter, a big portion of it focuses on UTI, and that's what we're going to focus on because it's such a prevalent and important issue. So about 10% of kids are going to have a febrile UTI in the first 2 years of life. And in infants and young children, the overall prevalence of UTIs in general is about 7%. The most important risk factor, because there's lots out there, there's lots of misnomers and things related to UTIs. The biggest factor for the development of a UTI is going to be urinary stasis. So the lack of that regular elimination or movement of the urine. Because when it sits in there at your body temperature, 98.6 roughly for everybody, it becomes a perfect medium for pathogens to grow in. But when it's moving, so you're voiding regularly, you're drinking, there's not enough time for that proliferation to occur. Highest risk are Caucasian children, females, and uncircumcised boys. And uncircumcised males that are younger than 3 months and females under 12 months have the highest risks. And then we're going to be talking about this concept of asymptomatic bacteria in the urine and in the urinary tract as we go through. So when we say asymptomatic bacteria, oh, I can never say this word right, bacteriuria, that means that there's a significant amount of bacteria in the urine, but there's no clinical symptoms. And so what's a significant amount? If anybody's wondering, it's not something that's ever going to be on your exam, but for your own knowledge, that means that there's more than about 100,000 colony-forming units. And again, no evidence of clinical infection. So no other symptoms, no other issues. That may be like an incidental finding. Then we have symptomatic, so bacteria in the urine with those physical signs that we're commonly aware of with the UTI. Pain with urination, suprapubic discomfort, pelvic discomfort, blood in the urine, fever. And now we're going to start differentiating, or try to anyways, the upper tract infections versus the lower tract infections. So this is where a lot of renal scarring will come into play if it occurs and it's not caught early. So the renal parenchyma, the pelvis, and the ureters. This is the UTI that you're going to see with fever, chills, and that flank pain up by the kidneys. Your lower tract infections are going to be obviously like your bladder, urethra, irritation, those kinds of things. And this is the kind of UTI that will present with no systemic manifestation, so it's not likely to have a fever with a lower tract UTI. Oh, and I was just going over this. So cystitis or urethritis, that's what I was saying, the bladder and the urethra. Upper tract, so that's going to be your pyelonephritis, the infection up in the kidneys, a vesicoureteral reflux, and glomerulonephritis, which we're going to go over those. Here is just a good review for you to look at. I liked this photo, it was right from the book. A little A&P reminder here, and then it has some nice, it points out where major sites of like urinary tract obstruction may occur. So when it comes to UTIs, there's a couple different types, again, from where we just were with different types. So there's recurrent, we have persistent, so the antibiotics are not helping. We've got febrile, so like I said, that's usually going to be your pyelo, and then urosepsis, so you've got a febrile UTI that's coexisting with systemic signs of bacterial illness. And now we're looking at urinary pathogens in blood. So if you didn't know, now you will. E. coli is the most common pathogen for UTI, followed up by streptococci, staphylococci, and very rarely, but occasionally, you might have a fungal or a parasitic pathogen. It is possible. Most often it's going to be like an E. coli. We have anatomic or physical causes. At this point, you should have heard this already in some capacity. Girls have a shorter urethra, less space to travel, more likely for pathogens to travel up the ureter that way. And then uncircumcised males. Like I said before, the single most important factor in the development of UTI is that urinary stasis, and vesicoureteral reflux may impact that, but it doesn't cause a UTI. The emptying of the bladder, obviously very important. I want to focus a little bit on the alteration of the defense mechanism. So meaning an actual dysfunction with being able to void. It could be anatomic abnormalities. There could be a neurogenic bladder. And then there can be extrinsic ureteral or bladder compression. And this is where constipation comes back into play. Because if there is enough constipation that there is pressure or an obstruction for the flow of urine to occur, then we've got these compounding factors of different issues. Okay. All of this is very basic. No need for me to really go over that piece. And again, very simple. Okay, page 850, there's a nice box there. It gives you the average symptoms, the rough estimated symptoms by age, which I think is helpful because symptoms really do vary dependent upon age. In general terms, just like our respiratory issues, the younger the child, the more severe the infection is going to be, and that's the same thing here with a UTI. Overall, your classic common symptoms are going to be, increased frequency. You may have a fever, you may not. There's going to be an odor to the urine. You may see frank blood, or it could be blood tinged in the urine. But overall, with all of that being said, even with a significant amount of bacteria in the urine, some kids still have no symptoms or have non-specific symptoms related to UTI, like feeling tired or just not hungry. So it makes it very challenging versus a teenager who most often has a UTI will have some burning, some discomfort, and they can verbalize that to you. And our younger kids, not so simple. There's like a whole page table of urine findings, just as a reminder if you're feeling the need to review that, if you're not super great with your UA stuff. That's table 26.2. It includes both normal and abnormal. And so here I want to just point out in some of the math calculation questions, I was asking you to calculate urine output in mils per kg per hour, and this is where that comes from if you were still unclear of why I was asking you to do that. Again, weight-based is going to give you a better representation, a more accurate representation of what's going on. And so in your newborns, we're looking at 1 to 2 mils per kg per hour, and in children, it's going to be roughly about 1. And so kind of keep those components in mind. I'm not going over the normal UA with you, but I did want to put it, I did keep the slide because I know a lot of you said you print these out and start this as your foundation for your notes. So at least here you have it. Same thing with this. There are so many diagnostic studies for UTIs and for urinary issues. The one that I really want you to focus on is going to be your UA and your culture and sensitivity. Because that's going to be what you primarily use when you're looking for UTIs. All these other ones, this is going to be big factors in looking at recurrent UTIs, why is it happening, what's going on, your pyelonephritis that continues, things like that. And so here, your dipstick, your quick UA is the quick and inexpensive way to determine what is going on in there. So when I'm checking urine and I have to order it like through the hospital, I do the dipstick UA with the reflex. So if there's something abnormal on there, then it gets sent for the microscopic analysis. And then from there, if something's still abnormal, then we send for culture. And the culture is really going to be the confirmation of what's going on, because that's where we're going to see what's growing. The age-old question, though, is how do you get the urine from the kiddo, especially from the younger ones? A clean catch is what we would really want. A U-bag for an infant, so that if no one's ever seen that, the U-bag is a bag, obviously. It has an adhesive on it, and you stick it around the genitals of a child, not like directly on it, but like on their pelvis. So from I should have had a picture up here, from like leg to leg, so that we're trying to catch what is provided. It's not the most ideal because obviously it's not a clean catch. We're getting what we can. So the most accurate results are obviously going to be a cath or a suprapubic needle aspiration because you're getting it directly from the source. I hate straight cathing kids. As a kid, I had a lot of renal issues, and so for me, straight cathing kids is always like just kind of like the worst thing. But sometimes it is necessary, especially in our younger ones. And for anyone who doesn't recall, the midstream catch is the way to go. So girls, you're going to wipe front to back. Boys are going to wipe around their urethra, pee a little bit, then catch your specimen. That is the best way and what we're really looking for. But again, in kids, it doesn't always work out that way. And in that case, then we're going to go to like a straight cath. Okay, so I mentioned the culture, and so then we're going to look at the sensitivity because that's going to determine the best antibiotic for providers to prescribe. If we have a suspected obstruction, then obviously we're going to be moving into some of those other radiographic scans that were on the slides before. Okay, so when we're talking about treatment for an uncomplicated cystitis, short-term course of antibiotics, usually going to be 7 to 10 days. For complicated, we're going to be talking about more of a long-term treatment. So these first three are going to be pretty common in your age range across the spectrum in peds. These other ones, like pyridium, it's an over-the-counter. You can get it yourself without a provider being involved. Excuse me. So for our repeated UTIs, then you're going to start talking about that prophylaxis or suppressive antibiotics. I'm not going to go in depth in that. Really, I just want you to be thinking about the acute kind of UTI. But in addition to the prevention with the prophylactic antibiotics, one of the most basic ways to prevent a UTI is good hygiene. And so with that, if you're taking care of teenage girls who are having sexual intercourse for the first time or engaging in any kind of sexual activity, educating them on proper hygiene, avoiding after sexual intercourse is going to be very important because I have seen regularly an increase in UTIs in adolescent females who are first time engaging in sex. All right, so vesicoureteral reflux, I mentioned it a few times. So it's an abnormal retrograde or backwards flow of bladder urine into the ureters. So it can be primary as a congenital abnormality, or it can be secondary as a relation to an acquired condition. Management, obviously the big goal is going to be preventing bacteria from reaching the kidneys. Low-dose antibiotics are great for that. There's going to be a culture to the urine anytime a kiddo has a fever or every couple months. VCUG, that's going to be a radiographic test to assess the status because there's different classifications which you don't need to know. Overall prognosis, what I want you to be able to remember is most children will outgrow it, but for the severe classifications, surgery may be needed. Okay, so moving on to acute pyelonephritis. I mentioned it a few times. This is going to be when it's up in the kidneys, okay? Whether that was from bacterial, from fungal, or protozoal, or viral. Again, most frequent causes here, you're going to see your E. coli. Klebsiella is very common, and so is Enterobacter. So manifestations, again, very similar to what we've been saying this whole time. They range from mild to classic and then to very severe. So this is where you think those systemic kind of symptoms: nausea, vomiting, overall chills, frequency, urgency. And here's where that low back pain comes in. Before I said an odor to urine, pylo urine is going to have a very, very foul smell. You'll have CVA tenderness. And sometimes, very often here, symptoms will subside on their own without therapy, but the infection itself still persists. And that's kind of where that scarring piece can come from. Same thing here. We're going to be getting your UA. We're going to be getting, this time though, a CBC and looking at your white blood cells. And this is where some of those other radiographic studies may come into play. Most people with pyelo end up needing to be hospitalized and needing a good dose of some parenteral antibiotics. It's common to get a relapse with this because, again, pyelo can seem like it goes away, but it doesn't completely. So sometimes they have to be put on like a 6-week course of antibiotics. I saw a lot of patients in home visiting getting the antibiotic at home for pyelo. Okay, moving on to nephrotic syndrome. So nephrotic syndrome is a clinical state that includes this massive proteinuria, hypoalbumin, I can't talk today, low albumin, high lipids, and edema. It is the most common presentation of a glomerular injury in children. I like my flow charts. I think they're helpful, especially when you have a lot of things going on like this one. So that's why this is here for you. So there are multiple kinds of nephrotic syndrome. The book focuses on MCNS, so the minimal change, and that's what we're focusing on because it makes up about 80% of the nephrotic syndrome cases. So this is going to occur mainly in our kiddos from 2 to 7. It's rare on the outer outliers of those ages, but it still can occur. And again, another one of those things, we sometimes just don't know why it happens. Contributing factors: metabolic, biochem, physiochemical, immune-mediated, pretty much runs the gambit of us as providers saying, we don't really know why it happens, but any of these things could be contributing factors. Here's your ongoing patho of how this happens. Again, if you're struggling to remember how some of these things occur, I highly encourage you to use flowcharts because it really simplifies it. When I'm describing something to you guys, I'm still thinking in terms of this happens and then there's an arrow, and then this happens and then there's an arrow, okay? So diagnosis is going to be based on your general clinical manifestations. What do we have going on? What does the urine look like? How much protein is there? And it is possible that a renal biopsy may need to occur, but in general, remember it's based on clinical manifestations. So treatment, our goals here are reducing that excretion of protein, reducing fluid retention, preventing infection, and minimizing any other kind of complications related to therapy and or ongoing issues. So supportive care like diet. We're looking at low to moderate protein. It's going to be low salt and fluid restrictions when cases are very severe. Steroids are your first line of therapy as far as medication goes, and we're looking at about 6 weeks of steroids, and so that's where that goal of minimizing complications from your therapies comes in, because steroids can have some pretty significant side effects. A major nursing role in kiddos with MCNS is going to be family support, especially in the instance where this becomes a chronic condition with multiple relapses. We're still working to make sure our kiddos meet their developmental milestones, and what does that look like within the family structure when they have this going on. Another big component within that family support is going to be education, because these kids are going to go home and they're going to have stuff still going on. So teaching how to do catheterizations, when to do it, when not to do it, prevention or infection prevention, all of our basic stuff, big important pieces to teach. Educating about the nutrition component, the fluids, all of those big issues that I was saying occur, families need to be educated about it in a way that they understand and retain, because they're going to leave. This is not the patient that's on the hospital floor the whole time. And this is all still educational components that you would be providing. I'm not going to ask you to know specifics here per se, but I want you to understand the concepts of what you would be educating about and why for this particular kiddo when they go home. Okay, so scooching on to acute glomerulonephritis, or AGN. Most commonly, it's going to be post-infectious, so we're going to talk about that specifically in a slide or two here. But it can also be a primary event. May also be like a secondary manifestation of another systemic disorder like lupus or sickle cell. So what is it and what happens? Generally, this is going to look like generalized edema due to decreased glomerular filtration, especially around the eyes. That facial edema is going to be more prominent in the morning, and then throughout the day, it kind of gets redistributed through the rest of the body. There's going to be some pretty significant hypertension due to an increased ECF. And then oliguria, so not urinating, due to severely reduced volumes because everything else has been spaced out to other areas of the body. There's going to be some pretty significant hematuria because we've got bleeding in the upper parts of the urinary tract, and this is a classic sign, the cola or tea-colored urine. And then the proteinuria here is also very significant, and it will be an indicator of the severity of the renal disease itself. So that acute post-infectious AGN most commonly is going to be post-streptococcal. It's going to occur after an initial strep infection, usually group A strep. And so when you're assessing, especially if you're an outpatient, and you're doing like phone triage, if you've got a family calling in about their kiddo, within a few weeks after having strep throat, this should be something that you think about and are assessing for. This can occur at any age. I've seen it in teenagers and I've seen it in younger kids, but it is most common in 6 to 7. We're not typically going to see it in kids under 2. Why? Because kids under 2 typically don't get group A beta hemolytic strep, right? And it is more common in boys in a 2-to-1 ratio. I don't know why. I've never been told why. I can't find why. It just is. So from the nursing standpoint, this kiddo is coming to the hospital. You're going to be monitoring for an acute hypertensive episode. So these kids need their blood pressures taken every 4 to 6 hours. We're managing their edema. So again, very simple pieces here, but very, very important. Their nutrition has to be modified. If they've already got edema, we want low sodium on board. If they have proteinuria, we want low to moderate protein in their diet. Bed rest is not necessary, and I think that's important because that goes along with maintaining the normal growth and development as much as possible in our acutely sick kids. So, quick question then. Clinical manifestations of nephrosis would include what? So, D, right? Massive proteinuria, low albumin, and edema. Real briefly, I want to mention Wilms tumor. What's on this slide is what I want you to know about it, just in a general sense, nothing in depth. Renal failure, it is mentioned in the book. The only thing that I really want you guys to be aware of are the differences in the acute and the chronic, and that's not very much different than adults, so it should be a review. So basically what's here is enough. This as well. Very straightforward stuff, nothing really to add. Same thing here. Okay, so that brings us to the end. I know this one was a little bit more, it was quicker because there's a lot less extra involvement that I felt like needs to be explained. It is very simple, but I wanted to give you some ideas on where to focus when you're reading and working on your notes and studying. And so I will see you guys next time.